do have a very distinguished panel this evening, just by way of a very quick introduction in case no one is 100% sure of filling in the blanks. Dr. Bernard Nolan is the director of the Eck Institute for Global Health at Notre Dame. He has devoted much of his career addressing diseases that disproportionately impact middle and lower income countries. From 2007 to 2017, he served as the deputy coordinator of the U.S. President's Malaria Initiative, and PMI expanded during the course of that time roughly to 27 high-burden countries in some of these areas of Africa and Southeast Asia. Over a 15-year period that corresponded with some of his work there, for example, the WHO reported a 60% decline in malaria deaths. So he brings a wealth of knowledge. If you want to learn more about him, you can do what I did and rip it off from the Notre Dame website, and you will feel terribly inadequate when you're done. Dr. Jennifer Abegno is very familiar to many people in the room, of course, an emergency room physician and professor. In a profile in the Times-Picayune, she was described as in many ways suited to be on the COVID pandemic front line. She said she led the city response to the pandemic and was in many ways the local face of the response. And Dr. Eric Griggs, or Doc Riggs, is a community health educator who has dedicated his professional life to raising health and wellness awareness in the New Orleans community. That might entail a serious discussion about a novel virus, or it might involve him dressing in a banana suit to talk about the importance of, eating healthy. But he is a frequent guest on Fox 8, providing viewers with a healthy dose of insight and humor. So our panel here this evening. Let us begin with Dr. Nolan, who's going to take some of the immediate pressure off me by giving a little bit of a look back at some of the history of pandemics.
Thank you. How many of you during COVID were in quarantine or isolation at one point? Okay. Well, quarantine. Let's see. Quarantine. So in 1348 in Venice was a huge maritime power, you can imagine, and plague was actually being spread from ships and rats coming from the Asian region and being brought to Europe. And Venice, being the major port for a lot of the entries of these ships, in 1348 set up the first quarantine laws. And what would happen is ships coming into Venice were forced to dock off. Actually, you can visit. This is an island off the coast of the lagoon in Venice called La Città Nuovo. You can actually go visit this. But ships were actually forced to park offshore before they could ever, for 40 days, before they could ever come on shore. And people who were symptomatic were taken off the ships and managed in these sorts of facilities. So 40 days, in Italian, is 40 giorno, which is where we get the term quarantine. So fortunately you weren't quarantined for 40 days, it was a lot shorter than that. And actually 40 days doesn't really have any scientific basis. It was actually, it has a religious significance, It rained 40 days and 40 nights. Christ went into the desert to fast for 40 days and 40 nights. So this term 40 had an association with trials and tribulations. So again, huge challenge. And of course, this was before anyone knew about germs and parasites and viruses and all this. So they're doing their best to try, with what they had, to try to control this. That's just one example. I'm going to just briefly talk about, and many of you are probably familiar with the whole problem of yellow fever, in addition to other diseases, in New Orleans. And in 1853, which was, it wasn't the only year there was yellow fever transmission in New Orleans, but it was kind of the worst year. I think there was an estimated 9,000 people in New Orleans that were died due to yellow fever, which is a horrendous way to die back then. And a lot of these were Scotsmen and Irishmen who came to make their fortunes in New Orleans, and it was called the stranger's disease even back then. Unfortunately, and many of you probably know the history here, but it actually affected the whole social milieu in New Orleans. So for example, those who were I think they use the term acclimated. Those who had survived yellow fever, been through yellow fever, were acclimated compared to those who were unacclimated. So recent arrivals were probably unacclimated, but it got into all sorts of things like, bosses would not hire those who were perceived to be unacclimated. Sometimes women would not marry men who were not acclimated. And unfortunately, because a lot of the Africans who had been brought under slavery had already had experience with yellow fever in Africa before they came, they were seen as somehow being resistant. So unfortunately, it also provided another rationale for the horrendous institution of slavery. So all sorts of things that this disease did to affect the structure here in New Orleans. And I mean, this is a little graph to show you the deaths in 1853, and as you can see, most of these deaths were in Europeans who had come fairly recently to New Orleans. Of course, now we have a vaccine for yellow fever, and it's not as big a threat. A few comments about the influenza epidemic of 1918, 1919, which has kind of misnamed the Spanish flu because it probably didn't start in Spain, it probably started in the United States and was taken to Europe by soldiers. If nothing else, it can give you an idea of how quickly these diseases can spread. So if you have a disease that, say you have 100 people infected today with a disease that's highly transmissible, and that doubles every day, by the 27th day, the whole population of the world will be infected. So again, this is just an example of that. And 10 to 20% of it, so it was not known until 15 years after the pandemic what actually caused it, which was an H1N2 influenza. This case fatality rate of 10 to 20% was extremely high, because again, most people, Americans seem to forget that on a good year here in the United States, 35 to 70,000 people died from seasonal flu, which is why we have these seasonal vaccinations. So, but the normal influenza case fatality rate is 0.1%. So, I love these pictures. Again, this is from the 1917-18 flu epidemic, 18-19 flu epidemic. Wear a mask or go to jail. And here's a picture of soldiers getting ready to go to France, and you can see they're all marching in masks on their way. Here's different headlines. The non-essential crowds are barred in epidemic war, except for churches and bars. And even in churches, you're supposed to leave the windows open. I love this open-faced sneezers are going to be arrested. So these are just different little vignettes and headlines. So what we just went through COVID-19, again, we've been through this before. And again, they were using the best tools they had at the time. And even this, this is, again, people pushing, snake oil salesmen pushing treatments for the virus, which didn't exist in the same way we saw during COVID, where some approaches to treatment had no basis, but people still continue to think they work.
Something we saved for a bit later. When you get old like me or older, you start to get cranky, and before COVID, I would yell at the TV when I would hear a national reporter or anchor say the worst flu season on record, because there was an uptick, and completely forgetting the history as we are prone to do, and we forget history as we've learned at our own peril. I don't want to put the two of you on the spot, and I'll do it to you first, Dr. Riggs, because you're going with the flow. Let me just just to kind of dovetail off that, just a couple opening remarks, and I'll let you do whatever theme you want. I prefer not to talk about the Fighting Irish and keep it on topic.
Thank you all for the opportunity to be here with such an esteemed and experienced panel and moderator. This whole topic of the pandemic, I think I mentioned earlier in the library, you compartmentalize it. This is something that none of us saw coming. And all of the education, all the books, all the science, med school, residency, experiences, illnesses, no one ever saw this coming. This was never a test question, right? I will never forget the first day. Everything was shut down, and I think it was John. Hey, Doc, can you stay around for a minute? And boom, everything shuts. I didn't get home until 6 to 8 hours later, and I'm like, I don't know what this is. Good, neither do we, but you know more than all of us. So let's figure out how can we explain it. The first thing that I identified was the feeling of stress. And there are two main hormones that pop out in our stressful states that make us fight or fly, and they're cortisol and epinephrine. The deer in headlights. And in med school, they called it the stupids. First year med student, they say, hey, what's your name? You don't think rationally, and that's where everyone was. I tell people that my superpower is I have super friends. And that's when you started making the calls out to the people that are experts in the field. Dr. Avegno, I said, you take the tower, I'll take the field, meaning that whatever the rules say, you let me know and I'll get it to the people and we'll figure out how to get it enacted. I had another partner in crime, or partner in COVID, I say, Dr. Mark Allen Derry, who happens to be an infectious disease doctor and epidemiologist. And I had my Fox 8 family that helped me with communicating, because it's not common knowledge. And John, you might notice this, when Paul asked about this lecture series, the first person that I thought about to moderate that would be most appropriate would be John, not just because of his knowledge and his ability, but because we've been through the battle and the war. But I don't know, John, if you ever noticed before, every day before we go on, I close my eyes for a minute, and that was actually the same reason that I ended up at Notre Dame. I went on my first tour, and I saw students praying at the grotto. And I told my grandmother immediately, I'm like, Ma, I don't think I want to go here. I'm like, wow, I said, there's people praying all the time. It's that hard? I don't know. And she said, no, baby, you go there. That's good. You'll find peace in it.
History and tradition is incredibly important. Not just Holy Cross Notre Dame, but in this being from New Orleans. When I took the health director job, which was not something I had a very circuitous past. If you ever were really a student of history and you want a laugh, read the New Orleans City Charter and I thought, I'm going to find out what it is I'm actually going to be doing in this job, because nobody could really tell me what I was going to be doing. And so when you read it, it was, parts of it were clearly written in the late 1800s, and I'm reading it and it says, I can quarantine a ship and a boarding house and a rooming house, and for infectious diseases I get to put a flag in front of someone's house and I get to pick the color of the flag. So I'm thinking, oh, this is hilarious, right? And so I had these funny conversations with my friends about what color would Ebola be? What color would measles be, right? Completely just thinking this is all funny, until the day that I had a serious conversation about quarantining a ship. And what I realized when COVID took us by surprise, and it was one of those, we knew it was coming, we heard about it, the information we were getting was terrible. The CDC was trying their best, but no one really understood, as we know now, that it was among us, and it was too late when it hit New Orleans very quickly. And so when we exploded that first week in March, I thought, oh, I better go back and read the charter, right? Figure out exactly what I'm supposed to be doing. But also the gift of history was invaluable. So John Barry, Tulane professor, wrote The Great Influenza, which I had read about the Spanish pandemic, and I thought, I better read this, because no one is alive right now that can help me with what we're going through. Yes, we have experts in Ebola and we have experts in various infectious disease, but none of them were alive for a global pandemic. So I read The Great Influenza. And then I said, well, I'm in New Orleans, I better read Yellow Fever. And so I read books on yellow fever. And I read The Plague by Albert Camus, and anything I could get my hands on. And what you say is absolutely true. The epidemic and the organism might change. But on a global scale, the response is repetitive, in that there is initially a great lack of understanding about what it is and what's happening. there is often an initial, we're all going to come together and we're going to figure this out. And then almost immediately there is a pushback because of fear and because of lack of understanding. In the flu, in yellow fever, in many others, you have oftentimes people saying, well, that's the disease of those people. I'm not one of those people, it's those people. So if we just do something for them, I can go about my life, I can keep my business open. Inevitably, that proves to be the wrong choice, and it proves to be destructive and harmful. But it's sort of like people are learning the lessons of history over and over again. And so for us locally, I was determined we would not repeat that because, you mentioned case fatality rates. In those first few weeks, it was just us in New York who were exploding. And so the best guess we had with the limited testing available is that our case fatality rate was 7%. Using some numbers, I found a model that predicted that for New Orleans, that meant that if we did nothing, if we let everything go along as usual, we would have 1,300 people dead in 8 weeks. And for a city of our size, can you imagine? And understanding that historically that had happened and the devastation that had followed really was all we had to go on. But I will say, 3-4 years later, we still don't have, we had a lot of people die in that very initial point, but we don't have 1,300 die. And if not for the lessons of history, I'm not sure what, that we would.
Let's talk about messaging. It seems to me that part of what happened here was that people were simply not used to the process. One day the CDC would say this, one day, Anthony Fauci would say that, and the net, and I'm not criticizing anyone, but the net effect of some of the messaging was we were all over the road. And did that confuse things for people who are used to living in a world that says, here's a pain pill, take this, it's fine?
At the root of all of this, the pandemic is a health literacy pandemic. You get a lot of people that will be like, yes, because we're all educated. But what people don't realize is that ignorance means lack of exposure, no matter how many degrees you have. You might have another profession, and I don't know your jargon. The urgency of the moment required the same level of authority that a parent would have a child to come in the house right now. And John, if you can remember, I was always saying, this is the equivalent of there being a big bad wolf. John, we talked about it. There's a wolf loose in the neighborhood, and you're trying to get all the kids in the house, and you don't have time to tell them why. In the sender message receiver equation for effective communication, we're used to, because we're used to being in a training setting, being professors and all being students, there's a lectern, you lecture, you take notes, there's little feedback, just making sure that the students understand what's said. But in effective communication, if you look at the equation, it's a bidirectional arrow, meaning that there is in the church, there's a call and response. In a communication equation, which is what, John, we go over when we go over different topics, you talk about it, you ask questions, and then you have the receiver give it back to make sure that there's a mutual understanding. The problem with COVID-19, when it hit us, was that not only was there lack of understanding, but that there was lack of context on both sides. There was lack of context from the messenger for the culture in the communities that the different factions lived in. There was no common themes. So what we went through, and the first thing I did, if you remember at the, first of all I called Jen, I'm like, Jen, they want me to stay here, I don't know what can I do? But I said, people don't know about the world of medicine, and they don't understand about the realm of public health. Went to med school ignorantly, I say, and no slight to my Notre Dame education, but my experience with public health was that was a place, as a kid, you would go to get your free shots and your physicals to go to camp or to play sports, and there was a nurse, and that was it. So when I went to med school and said, do you want to get a master's in public health, I just simply asked, my grandmother asked, well, baby, can you do anything with a master's that you can't do with a doctorate? What you need that for? I said, well, I don't know. I don't want to get no kids shots, and we do physicals anyway. So the first thing I had to do was I thought about basic learning, right? The first thing that you have to do is give people the words so they can contextualize the understanding of the concept. So I immediately thought, I said, my superpower is I have super friends. For some reason, I immediately went to the world of IT and thought about viruses. How do you handle viruses that can't be stopped? We've all seen the blue screen of death, those of us that are older than the internet. Back in the day, that would kill our computers. What languages, what words, what examples? I went to mechanics, I went to people in different professions to figure out how can I best get this to them. And the common thread in all of that is you have to give people the language. So if you remember at the very beginning, I was just talking about this is what the case fatality rate means. This is what public health means. Let's talk a little historical concept. And give it back to me and tell me how I can say that better to you. Once we got that mutual understanding, was right around the time that everyone decided to change up the language. Uh-oh, now I can understand what you're talking about. You don't know what you're doing. And that's exactly the perception and that doubt. I never thought that I would live through a period that the thing that I fell in love with most would be one of the things that I feared my life for when I left my house. And that's science and learning and helping. I can remember several times during this experience, we were vilified. I mean, people flipping me off at lights. I'm getting out to pump gas and then wanting to run up, and I'm sitting there, how about you, and fighting Irish to keep people away. But then what would happen is you have to agree. If you can remember at the very beginning of it with the message, before, when they first came out with the concept of a vaccine that was unfortunately named Operation Warp Speed, and it just so happened that the person that came up with the name was a Star Trek fan. And it created doubt. Well, I don't know who it was that asked me on air and said, Doc, when it comes out, will you be the first one to do it? And believe it or not, I said, no. Why not? I'm going to let you do it first. I've never seen a vaccine and the clinical trials process. I've been doing clinical trials 10, 15 years. I've never seen anything develop that fast. I don't understand it. So right now, I'm going to wait. And it was that moment that light bulbs went off. The tension started to go down, at least personally, in the community. People didn't want to fight me, but they wanted to ask questions. So possibly I could get them answered and you could ask them on the air.
Dr. Griggs, I think the challenge when there's something new happening, and this wasn't a newly recognized problem. It was the virus itself was a family virus, but it was new. There's a lot we didn't know. And there's people who get their PhDs in health communications, and I'm a big believer in that for the reasons you're talking about. It's hard for scientists to talk in a way, first of all, nobody wants to hear the I don't know. And there was a lot we didn't know early on. And a lot of the messaging around, for example, the first mask I had, one of my staff sewed it and dropped it off in my mailbox. You weren't supposed to mask, and part of what was driving that was making sure that the first responders actually had a mask, but also it wasn't totally clear that there was a lot of asymptomatic transmission, which we now know is a major mode of transmission. So everyone goes from don't bother mask, no masking, to everybody mask. And I can see why the public, they're like, what is going on here? Similar with the vaccine, when I heard they were starting clinical trials of the vaccine in July of 2020, I was thinking, if that vaccine is 30, 40% effective, that's good enough given the burden of disease. When the results came, it's like 95% effective in the safety profile. I was like shocked. And it's not that most people don't know, but there were vaccine developments for coronaviruses using this mRNA technology that preceded what actually happened. But I can see why the public is saying, like, someone cooked this up in their backyard, and how'd this happen so fast? But trying to communicate to the public as our knowledge is changing every day and hopefully increasing every day in a real time in the midst of a true public health emergency is a real challenge. And there's no perfect way to go about it. And part of that is trying to meet people where they are. And I'm sure Dr. Avegno and others have similar experience.
There's health communications and then there's crisis communications. And we spent a lot of time in medical school learning how to talk to patients and listen to patients and have a therapeutic communication with patients. That's fine when you have time. When you're an emergency physician, as I am, you do develop a skill of getting really good at delivering bad news in a very uncertain situation. And so what I think that public health got wrong a lot of times was acting with certainty when there was not that actual level of certainty. And then not contextualizing or explaining. What I think we tried to do, and remember, everyone is afraid. Everyone is coming from an emotional, fear-based response, because if we don't know what's going on and we have a little bit more likelihood, then how's the average guy, who's just trying to keep his job and feed his family and not die, how are they not afraid? And so when you're fearful and someone, if someone says, here is what we know and here is what we don't know, it might not make you feel great, but I think ultimately it's a lot better than saying, oh no, this is what you have to do right now, and then 2 months later came back and be like, well, no, this is what you have to do, right? Because then you've just lost that guy's trust, because you were not upfront. There were people who, because of their fear and because of the mistrust, were never going to like anything we had to say regardless. But I think what most people really resounded with is when we would, I would throw up a million graphs and say, here's where we are right now, and here's the level, and here's this, and this is what we still don't know. And you can be mad at me because I don't know, and that's fine, but at the end of the day, I think you feel like I'm being honest with you. And I have to say, I think no one really could have prepared. I don't want to throw CDC or public health under the bus, but I hope that for the next pandemic, we learn how to do that crisis messaging a little bit better.
Are you confident those discussions are happening among the people who would pull that off if this happens again in 2 years or 22 years?
It's going to be hard if it's in the next few years. Things have become so polarized now that it's not just the next big pandemic, but the misinformation and disinformation and mistrust has crept into so many things that the reason we're seeing measles outbreaks now, which we should never see because that's a completely preventable vaccine, is because it's just enough. I have a family member who has a 2-year-old, and I found out this weekend that she hasn't gotten him vaccinated because it's just a little bit of doubt, and she thought, well, he'll be fine. And that doubt, I know, came from so much of the misinformation that happened with COVID. So we have to rebuild what we're doing in the day-to-day before I think we can get the messaging right in a big pandemic.
I'm going to take a stronger stance. My answer is no. I'm not confident at all. With AI moving at light speed, it's going to be really hard in a 30-second bite on a TikTok and Instagram, or that's reaching millions of people with a click of a button, to discern what is true and what's not. During the pandemic, we had videos of people in hazmat suits talking about their cousins, brothers, friends, dogs, owners. Friend that worked at a hospital once said, now it could be you, it could be Dr. Malin, it could be myself, it could be anyone in this room in our voice saying something that's totally wrong. So it's going to take a lot more. The onus is going to take, while we have this window to teach people how to discern what's true and what's not, how to read an article, what's clickbait, that it's okay to ask a question. It's okay for an expert to say they don't know and to ask, is there any way that I can help? So I don't know if those conversations are happening right now, because this whole AI technology thing is moving at light speed.
You have to be a bit of an optimist to remain in this business. And again, the fact that we kind of forgot the lessons of history. I mean, I could show others, for example, there's pictures of protests in the streets of San Francisco in the Spanish flu epidemic because people didn't want masks. So we've been through this stuff before. And frankly, there will be a pandemic sooner rather than later. The speed at which things happen these days is something with transportation, so there will be a pandemic sooner rather than later. We don't know exactly what it will look like. We can kind of guess what it might look like, but also the speed at which disinformation. And I'm a bit of a Luddite. I'm not on Facebook or TikTok or Twitter. I'm on LinkedIn because Notre Dame forced me to be on LinkedIn. So I'm not in the middle of social media, but I understand the power of that, both in the good, but frankly, the speed at which people can create the little silos and spread disinformation and frankly, I find it sad as people working in the public health arena, and if we've seen this, I'm sure you've all dealt with it, where people trying to do their best on behalf of the public are seen as the enemy. I just find that incredibly tragic, and hopefully that can be turned around. You know, someone like Tony Fauci, who I know personally, the fact that he's called out by politicians and Tony has 24-hour protection now, that should be unacceptable in any country. And how we reverse that, I don't know, but I hope we can figure out ways beyond this. It is about, the other thing we haven't talked about, the importance of political leadership in the midst of what's unknown. And not surprisingly, some parts of the United States did better than others because people are willing to listen to religious leaders, to political leaders, to community leaders, and a level of trust where it can't just be the physicians and the public health people.
My question is that, so I've heard you all talk about leadership needing to be more data-driven, more emotionally intelligent, and, on the communication side. What else would you say are opportunities for growth in preparation for the next wave, right? Like, what else did we not quite get right so we can be proactive in doing better next time?
Well, I think we all we all want to invest in the next generation of public health and global health practitioners, and I think you mentioned AI. I mean, I was at the other day I was at another meeting in Los Angeles on how AI could be used in a positive. And any new technology, there's a potential downside too. But there are these new things going on. I work a lot in global health, and in most of the places, Notre Dame, we do research. The healthcare system is very weak, but now some of the new technologies, like a stethoscope that you could use, that actually you could do an EKG, could do the respiratory rate. That's going to revolutionize healthcare in underserved communities, not only in Africa and Latin America and parts of Asia, but in our own country. If nothing, when I think of some of the good things COVID might have done, hopefully we won't forget these, it really shone a spotlight on the health disparities in our own country, which we know exist, but we can kind of ignore it. But even in South Bend, Indiana, if you look at the hospitalization rates and the death rates from COVID, it was primarily communities of color. And paradoxically, these are the communities who were seen as being essential workers suddenly, because they're the ones who need to drive the trucks and be in the grocery stores and all these others. So that's something with the Notre Dame students I'm working with, and they come from different states and different countries, is again trying to look at this in a way so next time around. Last but not least, I just go back to the importance of investing in research. We mentioned the rapidity with which the COVID vaccine, again, that didn't happen overnight. And actually the two people who won the Nobel Prize for Medicine this year for developing this mRNA technology, that was something they started when they were early in their careers at the University of Pennsylvania. So what's going on now, we don't really know, but when it comes to diagnostic, I could go on and I won't, but just quickly, when I was in medical school, 1981 was the first cluster of cases that were reported in India for what we now know as AIDS. Nobody knew what it was. So that was in July of 1981. It wasn't until a year and a half later that a virus was attached to what we now know as AIDS. It took another 2.5 years to have a commercially available diagnostic test. I was assigned to Los Angeles for part of my career to work on AIDS, assigned by CDC, and I was working in a clinic at LA County Hospital. All my patients were dying. We only had AZT, the one drug. By the time I left to move to Kenya, 1992, we had triple drug. So now AIDS is not seen as the sort of death sentence it was in those days, but you look at the time it was discovered to the time we had effect, that was over a decade. COVID, you know, the genetic code is printed, there's diagnostic tests almost immediately. We now have effective vaccines, we have a couple of great drugs, and so it's just the rapidity. So yeah, there are some positive things going on.
Keep the conversation going. We're here now, having this conversation. The way that AIDS has become destigmatized, can be seen as a chronic disease now. You have, when I give my talks, I'm talking more about diabetes and hypertension because everyone understands. It's not something that's taboo. We need the conversation, keep the conversation going. We were talking about the next pandemic is coming sooner than later. We need to keep talking about it so there's not a fear. It's educated conversations because you are the trusted voices in your respective communities. We're always here as a resource, and you can always help de-vilify science when it starts if you stomp on the center before it becomes a spark.
Yes.
I just wanted to bring up, how are they studying the mental health aspect of the whole shutdown and everything? Because
One of the things I wish that I could have found a way to communicate when we were shutting down and we had the very strict restrictions is that when I was trying, calculating the potential death rate, I was also trying to understand what are the long-term, short, medium, and long-term unintended consequences of this. What does it mean to completely disrupt the economy? How many businesses close? What does the business closure lead? How many heart attacks does that lead to? Will violent crime go up? And I had an inkling that might happen because of Katrina, because what we saw post-Katrina is that it was very similar. It was a complete disruption. And in the first couple of months to year, everybody is just trying to survive, pulling together, focusing on your immediate needs. But then what we started to see in the healthcare system was delayed. So a year, 2 years post-Katrina, we started to see a rise in cardiac arrest, heart disease, violent crime spiked. And I'm a sociology major at Notre Dame, so I understand that when you disrupt the social norms so completely, there are those consequences. The problem is when you've got the wolf at your door and maybe there's a leopard somewhere out there, you got to deal with the wolf first, right? But that was all, so when people would get mad about we're shutting down and this and that, I wanted to say, but yes, I don't ever think that this doesn't weigh into the calculus, but we're staring death in the face. And so what I think that we have seen is, we didn't have a great mental health system before. And this taxed it to the brink. And I say that as a mother of 4 teenagers who went through COVID. It was awful. It was awful for them. And we are trying to heal from that. Our physical wounds for many of us, although those who have long COVID may disagree, but our physical wounds largely, if we've survived COVID, we're generally okay, but it is the prolonged tail of the epidemic that I think we're going to be dealing with for quite some time.
The whole issue of the mental health crisis, which was there before but is made worse by COVID, part of the, Notre Dame just launched their next 10-year strategic plan, and one of the key focuses there is actually mental health. And even in South Bend, the psychology department is building a whole new building to address mental health issues. And again, next time around, I guess a question I would have to ourselves, like what do you close down and what do you not need to close down? I think we've learned that probably closing down schools is probably not something you want to do. Notre Dame figured out how to stay open. I know other schools didn't, but I think that's had all sorts of negative consequences for young people.
Dr. Orlando brought up the measles issue. I'm a general pediatrician, and the, damage from coming out of the pandemic that did to people's mistrust in science and misinformation. It's really scary, and I know we think about measles as a highly transmissible virus, right? Kind of a bellwether for other childhood illnesses. And I don't really have a specific question, but just something that's on my mind. If you guys have any suggestions on how to kind of rebuild that trust in science and medicine.
You guys have the hardest job. Hug a pediatrician. There's a reason I didn't go into pediatrics because I wasn't tough enough. You have to deal with terrible things happening to little people and then their parents,
Right.
who are generally the worst, as a parent. But I do think, again, when I had these discussions with my family members, it took, what I wanted to say was, oh my God, do you know we just had 2 cases of measles in the New Orleans area, and do you know the rates of measles encephalitis? And my sweet, lovely little 2-year-old cousin, oh my God, I don't want you to die of, measles encephalitis, but you can't, right? That never works. It has to be, an opening conversation from a place of love, and from a place of compassion, and a place of, you and I both want your child to grow up healthy. We're going to start from there. Let me tell you what I know and what I'm seeing and why I don't want that to happen to your child. And we had a conversation. I'm going to have a lot more like that. You don't have that luxury of time, except maybe you do. Maybe it's just opening the conversation, making the person feel validated and heard and listening and not threatened or not rushed out of there. If making sure you hear their concerns, but that's hard when you're seeing 30 patients a day. I don't know. I think it's a long game. You and I used to talk about that. It's not a short game, it is a long game.
Well, and particularly since you're going to be, hopefully you'll still be seeing this kid after that interaction. The best way that I learned to diffuse the situation is to listen 5 times, talk once. John, if you can remember it, then we talked about it. I said, listen, I'm not here to change your mind. I'm just here to tell you everything it is that I know. Tell me why. Because what happened is that people that didn't believe or didn't want a vaccine, they come in with their fist balled up and they're ready. They think you're going to judge them because you're on the side of science. And you're a person first. So let me hear what it is you have to say. I'll acknowledge, and then hear what I have to say, and then you make your own decision. And ironically, I can't tell you how many people have walked up and said, you know what, I've been thinking about it. And I got my jab because you actually listened to me and didn't make me feel like I was wrong. It's worth a shot with an angry mom and dad, right?
So I have a question about our response to the pandemic originally. So to me, it seemed like we weren't erring on the side of caution. So in China, we knew that it was mostly older folks who were having the worst outcomes from the pandemic. In Italy, right, it was significant there as well. And then it showed up first in U.S., in Washington, in a nursing home. So to me, those 3 points of information should have, at least to me, just as I'm watching this as a regular person trying to find things to do during the pandemic, it's like, why didn't we just shut down most, if not all, nursing homes before it started to spread? Nursing homes accounted for 40% of the deaths.
Something that we had talked about and we wanted to defer. He's asking if we noticed that it seemed like it started in China, then it would go to, John, we said this at the station, it would start in China, go to Europe, it would hit New York, make its way down to us, then go to California. And it was just the same pattern. It's like playing tic-tac-toe, it seemed like. Why didn't we notice the pattern early? Is that what I'm hearing? Is that what you're asking?
Yeah, particularly as it relates to older adults.
Why didn't we protect older people earlier?
Frankly, shutting down travel, the horse is already out of the barn, and shutting down travel, even the spread here in New Orleans, it was already, by the time the U.S. government decided to shut down flights coming in from Europe, and that was not a very effective response. The speed at which these things happen these days is a real challenge. There are some diseases where like Ebola, which is not as easily transmitted, where you can limit, you can shut down, you can close borders. But some of these, particularly some of these viruses we're talking about that are transmitted so easily, and particularly in the case of COVID, where there's a lot of asymptomatic transmission, it's just not an effective strategy. If it were, the countries that try to do this, and We could go to a place like New Zealand, which is an island, and they did do that. But that's kind of a particular place where you could do that if you actually don't have any borders with other countries and you don't rely on international trade. But frankly, the U.S. response to start shutting down travel was way too late, and I don't think it could have been done in a way effectively to made it an effective tool for this particular. And I got to just go back. Epidemics, pandemics are different, so there may be some situations where that might make sense, but certainly not in these searches.
And even more specific to your question, you're talking about protecting our most vulnerable, right? Which are the extremes of age, our young and our elderly. That's where you're going to get the most pushback. Dr. Avegno just talked about sociology, and she said when you compartmentalize societies quickly, can you imagine someone calling and saying, we're shutting down the nursing home or we're shutting down the preschool, and we're not going to tell you why, but we got to shut those down first without a full explanation. You're involving the entire family, so it's hard to pick one segment of our community without affecting all of them.
4 in the morning as I'm driving in. The BBC was probably the major international news organization that jumped on this story first and talked about a virus hitting China. And there was a long interview with a mask maker in Texas. The interviewer said, "What do you need from your government?" He said, "I need my government to wake up or we're going to run out of supply." And it was, and I looked up the company and I almost bought 100 masks. I'm talking January. I'm weeks away from most people in America even knowing this happened. And I thought, I'm not going to do that. My wife is an RN. She was given one mask that normally would be discarded. And after the use, the mask was for a period of time put in a plastic bag, and she would bring it home at night, and that was her mask for the week. And I remember thinking to myself, if I had bought those masks, those medical masks, I would have been supplying the mask for the endoscopy department at the hospital kind of under the table. So that's where we were. So just if each of you would take a minute, maybe we'll begin with you, Dr. Avegno, to just have the stage. If you want to talk about what went right or just whatever closing remark you have.
I'll speak locally. I think people in New Orleans have an idea of what public health is now. And I can say that I didn't even before I took this job. What I can also say is that thanks to Doc Riggs and others, and particularly our state health department, we were able to show that you do not have to replicate health inequities if you work really, really hard to disrupt them. Louisiana is the only state, might be one other, but for a long time the only state where our vaccination rate of people of color, particularly black people, was higher than the white rate. Part of that is politics, right? But a lot of that is because we knew that our communities of color were the most vulnerable because of intergenerational living, the types of jobs, and historic lack of access and health inequities. And we worked really hard. We had the first community testing sites in the country, and the feds thought we were nuts and just wanted to get us off their back, and so said, fine, go ahead and do your stupid little community site. And we did, and that's all we did. And because of that, we're now in all of the other work that we're doing, we have that model. We have partners that trust us now. We have partners we can work with to dismantle some of the other terrible health outcomes that we historically have had in New Orleans. So I would never wish another pandemic on my worst enemy, but it did show us that there could be a different way.
So, John, give me a minute. And in the spirit of Notre Dame, in the spirit of education, in the spirit of community, I was taught by my family that you should always give people flowers when they're alive. We, here in this room, went from the number 3. It was a double dose of cortisol and epinephrine because we were number 3 at one point in the world, it seemed. Number one, fastest death rate, yes, and she's talking, but the person sitting to my left is responsible for us being number 1 in flattening the curve, and I will take my minute to, can we just please?
Sounds like we need to clone a couple of people here on that. Right on that. Well, what went right? First of all, I think, we always talk about how interconnected we are as humans at a very local level. I think now at a local level, people with more resources realize how dependent they are on people with lower resources and how community is important. Previously talking to students or others, you say, hey, what happens in a remote corner of the world can affect what you're doing here. Now you've lived it in real time. And I think people understand the importance of, so a couple of things I think we've gone right. We can all, lots of things that didn't go that well, but the investment in science. Like I said, I mentioned that it's still mind-boggling to me that for something as new and with such a huge burden on not only human health, but the economic burden, we haven't talked about that as much, within a year, we had effective treatments and effective vaccines. And that continues. I can tell you that there's a lot of research going on now trying to predict what the next vaccine is, what the next pathogen is, and how we're going to use the vaccines. And then, last but not least, again, being in an academic institution, there's a tremendous amount of interest among young people now in science and medicine and public health in a way. It was always there, but now I think that's a positive thing if people want to commit their careers to trying to deal with what nature's going to throw at us in the future.
Dr. Nolan is actually the one who had suggested a question about, the positives or takeaway, and I'm so glad we did. I hope you enjoyed this half as much as I did. I really, I kind of forgot I was up here a couple times. My old dear partner, Nancy Parker, used to say, I forgot I was on TV. And that seldom happens with me, but I forgot I was doing this because I would just sit back in just a little bit of awe sometimes at the knowledge here. And thank you so much for your time. And again, I'm honored to have done it. Thank you.